This
Can you all see
conference will
this?
now be recorded.
Yeah, we can see it.
Okay, there you go. Okay, so I guess I'll start. This is our first slide. We thought that Foundation Medicine had a very interesting presentation, basically comparing circulating tumor DNA versus biopsy DNA. And there's a huge overlap, as you can see from this data in the lower right-hand corner, that they are very much concordant. So if you can't get a somatic, a tumor sample, circulating DNA gives lots of information. And there are some issues with Foundation Medicine in the sense that you can see it doesn't, while it can do BRCA1 mutations, and there was great concordance, it doesn't do deletions. They also seem not to do TM, PRS, SERG, and SPOP, but for people who are interested more in mutations, I think that it does the job. Len, did you want to add to that?
No, nothing more on this slide for me to, well, this 93% concordance, did you mention that?
Yeah, it's right there, right.
Yeah.
At least for BRCA, right?
For BRCA, yeah.
So any questions from the folks?
Can you please explain what the quadrant is in the right-hand corner for the
My
30
problem, my
uneducated?
screen is, for some reason, I've never presented here. Okay, let's turn this off. It's blocking. I can't somehow go to meeting is blocking my ability to see the slide. But the lower right-hand quadrant is, for example, on the liquid biopsy is the vertical axis and
Right.
tumor sample is horizontal. And that's what they detect wild type and they detect mutation. And what you can see is the concordance is very high, that the agreement between the liquid and wild type biopsy in terms of the numbers of samples that overlap is very, very high. And the disagreement is pretty low.
Okay.
Herb, can
So
you
that's-
briefly describe what a BRCA deletion is?
Okay, basically it means that you don't have the gene, that for some reason there was a mutation in the gene that it doesn't even make the protein. So it's not that it makes a mutated protein, it just doesn't even make the protein. So lots of times when you have a problem in your genetic, that something changes in DNA, it just actually, the DNA never gets made into protein if there's something wrong. It not just doesn't, other times it makes mutated protein. So any questions about this?
Well, Herb, I was
Yes.
going to, I think we have some information regarding liquid versus tissue biopsy with regard to BRCA coming up, but I guess I'll mention it here since we're talking about the agreement between liquid and tissue biopsy. And just want to mention that De Bono in a roundtable discussion said that for him, tissue was still the gold standard, and that there are issues with the liquid biopsy if the number, the amount of mutations is very low, and there could be some interference from something they call clonal hematopoiesis, which simply means that there are mutations that we see in prostate cancer cells that are actually, that can be picked up in a liquid biopsy, but they are not actually from prostate cancer cells. They're coming from blood cells, leukocytes, which are made in the bone marrow. So it would almost suggest a potential false positive. result with liquid biopsy. It seemed to have the biggest effect with ATM mutations.
I have a question, if
Yep.
you're ready. My question is, how durable are these results with regard to mutations and such? I was not able to get a clean biopsy for tissue back in December of 2019. But if I had a biopsy that showed something prior to that, would those results be durable today, or is this a constantly changing picture as the cancer evolves?
I think the answer is that it could very well be a changing picture. And that the biopsy you had at initial biopsy may be different than your current status today.
Okay.
Yeah, I agree with that. I had
And-
one in 2019. I had another one just recently, and I had some identified in 2019 that were no longer identified in 2021, and new ones identified in 2021.
Yeah, so I've had 2 rounds of chemotherapy, carbazitaxel, carboplatin, and docetaxel. So I expect that my cancer's moved on and evolved beyond what it was a year or 2 ago.
Right. So in that case, a liquid biopsy may be a good option. Okay, I'm going to move on.
Can I just make one point for everybody? When we talk about a solid tumor biopsy, a solid tumor biopsy should be soft tissue. Once you start decomposing bone tissue, the chemicals that are used to decompose the bone can bring in some distortion. So I would agree with De Bono, but only as far as soft tissue. So the order is soft tissue, blood, and then bone.
Right.
And that's according to FMI.
Okay, next. So then there were several posters, presentations about olaparib. Okay, and what the, olaparib being a PARP inhibitor, one of the class of PARP inhibitors, really has been touted for a lot of different effectiveness to cause synthetic lethality with many different mutations. But in fact, it seems that what I read here is that it really has a better effect if for BRCA2 versus BRCA1. And and then we'll go on to this in the next slide, whether it actually has efficacy with other mutations in DNA repair pathways seem to still be up in the air. Glenn, would you take over there?
Well, you want to go to the next slide where I think I had made some additional comments. Oh yeah, so some of this is what I already mentioned. This is from the roundtable discussion on olaparib, where De Bono backed off on the efficacy of olaparib for anything except the BRCA mutations. So as you guys may well remember, the FDA approved of olaparib for BRCA1 and 2, ATM, CDK12, and a whole basket full of other mutations for which there was very little evidence. And so this woman, Dr. Silke Gillesen from Switzerland, questioned him about that. And he said, this is a quote from him. Now he's just saying, well, activity was observed in patients with alterations in ATM and CDK12, supporting the need for further studies. So, the way I interpreted that was we really don't know how effective olaparib is with any mutation other than BRCA1 and 2.
Right. I
Uh,
agree.
yeah. And EMEA, for guys who aren't familiar with that, that's European Medicines Agency. It's Europe's equivalent of the FDA. They only approved olaparib for BRCA1 and 2, nothing else. That's it for me, Herb.
Right. Any questions?
Well, I just want to say that Len's being very, very modest here, because a year ago, we picked up on this through the research that Len did. And we went back to FMI and we said to them, this olaparib approval is not what it seems to be. So for those of you, and I know Jake remembers this well, you heard it here first.
Okay.
Hey, let's get another $5 from Bill and move on.
Right. So here is another study with an olaparib in combination with a tyrosine kinase inhibitor. Len, you should talk about this one.
Yeah, so as Herb just said, cediranib is a protein kinase inhibitor of this VEGFR, which is vascular endothelial growth factor receptor. So the importance of this is that this cediranib can induce anti-angiogenic hypoxic tumor environments. Anti-angiogenic means it prevents blood vessels from forming in the tumor microenvironment, and of course, without a blood supply, the tumor is going to die. So they combined cediranib with olaparib, and let's see. This must be your. Yeah, you put this chart
I put
in
the
here.
table in because the table gives the data that basically the combination, if you look at median survival
Yeah,
and
here we go.
overall survival, it's kind of not that great, right? Len, I don't know whether you thought
Well,
so, but
I had a slide maybe further down, which it was extracted from the table. It made it a little more clear. I think it was this, maybe it was a cediranib plus olaparib, C plus O here. 10.6 was the median progression-free survival, whereas olaparib alone was 3.8. So that's quite a difference. Of course, it wasn't statistically significant, as you can see under the p-value, but that's because it was a very small number of patients.
right.
But nevertheless, it's an interesting trend, and I'm sure they'll go ahead with this combination in a phase 3 trial.
I mean, I think more and more what we're seeing is, again, combinations pop it. Lots of phase 2, phase 1 trials are using various combinations of things. The next slide is a report of the ASIS trial. And Len, you could talk about this one too. I mean,
You go ahead, Herb.
okay, so basically here they're comparing in metastatic castration-resistant prostate cancer using apalutamide and abiraterone and prednisone versus abiraterone and prednisone alone. And these are progression-free survival as designated by the investigator, and this was presented by Dana Rathkoff. And what you can see here is the green line is abiraterone alone, and the blue line is the combination. And at least in terms of progression-free survival, that at 50%, it's 7.4 months difference, which is quite a significant difference. So here it looks to us like the combination is certainly an advantage rather than abiraterone alone. And they didn't stratify by any other parameters.
Hmm.
Any questions about this?
What did they report on side effects in this?
Well, they did, and I think they're the usual side effects. But they didn't, again, none of these reported, grade 3 or 4 where there was a huge dropout.
I guess what I'm asking is, was there a significant difference in side effects between the abiraterone alone and the abiraterone plus the apalutamide?
That's a good question, Rick, and I don't remember.
There were increased side effects with the combination. Exactly how much worse, I don't recall. I think I just have a general recollection that it was kind of a moderate increase in the toxicity, and in the same, mostly fatigue, additional fatigue,
Right.
which you would expect.
No, because I remember this trial was offered to one or two of our guys. I cannot remember who, but I definitely remember the trial was offered. And one of the concerns we had was that taking the two together might really whack you with side effects.
Yeah, Rick, this study kind of surprised me. I don't know if you recall, quite a few years ago, we had a guy up from Canada who entered a clinical trial with abiraterone and enzalutamide, and it sure didn't help him at all.
Yeah.
And I thought that they just abandoned that approach of combining abiraterone with the receptor blocker. You remember that?
Well, I do remember that they, excuse me, had previous trials with combining with enzalutamide, and they never seemed to show too much. But this is significant. I mean, especially with, is it 240? How many patients were involved in this?
Yeah, well, quite a few. Look, it starts at 492.
Yeah.
490 in each group.
Okay.
So that's
So,
quite a few.
Significant number of patients, and that's a big difference. I remember when abiraterone or one of them first got approved, Xtandi, it was only like a 4-month difference, and everybody said, "Well, what's the point?" So
these subjects, Herb or Len, these subjects had all had biochemical failure on ADT, right? I wonder how long it was since between the time of their biochemical failure and when they got into this study, if it was a long time or really quick.
That I can't, I mean, again, I should have extracted that data. Now that I hear the kinds of questions you're asking, next time I do this, I'll be more prepared.
we're a tough crew, Herb.
I realize that.
You're dealing with a bunch of pussies here. What did you think, Herb?
Okay, we're going to move on. And then here's again apalutamide and another trial where they did abiraterone and prednisone and docetaxel. This is a new phase 1 trial, and it's out of Weill Cornell. So the previous one with abiraterone and apalutamide was across the street from Memorial. This is from Weill Cornell, and this is the beginning of their phase 1 trial. And they're really clobbering people with everything, with both abiraterone, apalutamide, and Taxol. But their initial results, if you look at the waterfall plot, quite a few have a big drop in PSA. And if you look at the percent survival in the Kaplan-Meier plot, they're optimistic. Obviously, there were lots of grade 3 side effects in this trial, especially with the docetaxel, as you would expect. There's hematopoietic side effects for sure. But again, this is a phase 1, so we don't know where I just thought it was interesting because basically it just means they're piling on more and more in terms of these trials. Any questions about this?
I just feel sorry for those subjects.
Well, yeah, I agree.
Do we have a name for this trial? Pat Martin asks, do we have a name for this
Well,
trial?
there might be, and I'm sure I can find it on,
Okay.
and, you know, put some stuff in the chat window and I'll follow, and then we'll follow up with questions. That's going to be the easiest way.
Okay, it's in the chat window. That was in the chat window.
I can't break out of the presentation in order to,
Okay.
to see. Okay, next. Okay, here, I think this is,
Yeah, this was mine. So here they had sequential use of abi and enzalutamide. So first abiraterone, then when patients failed that, they put them on enzalutamide. This was, I guess, a fairly large study. It says from 7 UK centers, and the time to treatment, time to progression, TTP, was less than 16 weeks. So that's not very good. So enzalutamide following abiraterone, not very good.
right. But again, they're combining.
Yeah, which I thought they did already, but I'll have to research that. Okay,
Next.
next slide.
Okay, so the next style is basically, here's a group where this is actually a retrospective study, not very many patients selected from a huge number of patients, where they repeatedly challenged with cabazitaxel and found, you know, here's best clinical benefit improved, stable. This is the percentage of 22 patients. And basically, you know, even in the fourth use of cabazitaxel, and these are basically cycles of cabazitaxel with breaks in between looking for PSA, they're getting a response. So the only thing for me was that this is a retrospective study where they started looking at 700 patient records and evidently only found 22 that had 3 uses of cabazitaxel or more. So I suppose if you can take 3, you can take 4 and 5 if you need it. Which I thought this was pretty interesting just because of the fact that it continues to work. Any questions here?
Do you recall if these patients were pre-treated with docetaxel before they did the cabazitaxel?
Some of them were. I don't think they were all. They think they were all heavily. If in fact, there's a graph there which basically says even in between these different treatments of docetaxel, they were getting different things. They were getting immunotherapy. They were getting other second generation anti-androgens. So they were getting a lot of stuff thrown at them, even interspersed with these courses of cabazitaxel.
So, I mean, so to me, that really doesn't help a lot because you're comparing apples to oranges. You know, you don't know by the time you get to the 4th round if the guy who got Keytruda after the 2nd round is having an effect.
Yeah.
Especially with an N of 22.
Right. I mean, that's all this is again extracted from records, but
yeah. I mean, I just question the premise of the whole analysis when it's not a constant.
Mm-hmm. But okay, we'll move
thanks
on.
for recording.
We'll move on. And then, okay, I think Len can talk about this one.
No, that's your slide, Herb.
It is? Okay.
It is.
But I mean, basically, that it basically here, when they used docetaxel rechallenge, they didn't get a great response. So in the previous one, they sort of are intimating that cabazitaxel can be used, but here the numbers for me were not that great. You know, among 44 patients, 23% had a PSA 50 and 5%, the median time to progression was 2.3 months. So to me, that says that if you really are failing docetaxel, that coming back with the same thing is not that great an option. It's time to look to something else. Rick, would
Is
you
that
have?
meant to say a PSA of 50?
I'm
Sorry, whoever that was, please repeat. We can't hear you.
This is Bill. Was that meant to say a PSA of 50?
No, that PSA 50 means a 50% reduction in PSA.
Right.
Oh, okay. Thanks.
Yeah, PSA 50. You know, I mean, what's interesting is Ken Anderson's on here, and he certainly doesn't fit into the results. I mean, Ken, you're the outlier here, don't you
Ken?
think?
Yeah, I would say I am. I have no idea, why, but Paul continues to think it's going to be my like maintenance program. So we'll see how it goes the next round.
Right.
But, you know, we've got 23% achieved at least PSA 50. Well, you got PSA 50, right? Ken, from the original number?
Yeah, right now I'm sitting at 72%.
Well, that's, you're in the you're up there
Yeah.
in the 18%, having a 50 to 90% reduction. I mean, I think what really, again, everything, and I mean, maybe I'm not the one to opine on this, is we're all so different. That these numbers are summary, but each of us are different.
Yeah. Yeah, this is what we always say. And you look at that overall survival of 11 months. I mean, Ken, God bless him, has been on the docetaxel for more than 11 months.
Exactly. So I think every one of us are different, and that's why these they give us a window and a glimpse. But I don't think there's nothing here that's in stone for any particular person. Okay, moving on.
Could I ask a question about the previous slide?
Sure.
So when they say they're all of that stuff challenge following chemohormonal, so they're including the full range of hormonal therapies first? They're meaning
Yes.
like someone was on Lupron and then they added darolutamide, whatever. And then after that stopped working, they went to try to re-challenge with docetaxel.
Right. I think
Okay.
that's correct, Larry.
So it could be like multiple steps on chemohormonal therapy.
Yes.
Right. Right, which is exactly what Ken did, Paul Corner's done with Ken, Larry.
Yeah, okay, thank you. Yeah, I thought that's what it was going to mean.
Okay, so here is something else which was it's a trial, it's a phase. We don't have any results but any definitive results. But this is interesting, where it's a phase 2 trial where they used the PD-1 inhibition combined with SABR to metastasis, but they didn't. The patients had lots of metastasis, but they only radiated 2 sites in addition to this PD-1 inhibition. But it seemed to increase progression-free survival and overall survival. So this is, to me, would have been sort of a test of what we've been hearing about called the Ebscopal Effect, that the idea that even just radiating 2 nodes, not every node, seemed to increase the efficacy of immunotherapy.
Yeah.
So it's a trial which we could see what happens in the future.
Wow. We should call
How
this
strange
the
and interesting.
Lupron Gym. We call this the Lupron Gym trial, I think. Right? What do you think, Len?
Well, yeah, but Jim only had SBRT. He didn't have avelumab or any other kind of immunosuppressant.
Right.
Which makes me wonder, that how pure a test of abscopal effect this is, because you do have the potential added boost of the checkpoint inhibitor that's helping out here. By the way, I guess most guys know, but just in case to clarify, SABR, SABR is the same thing as SBRT.
Right.
Yep.
Just very localized radiation to metastases. I just thought it was interesting. The fact that they did result, that there was a significant difference in both outcomes.
Did they have a control in this? Did they compare this to somebody who just got avelumab?
Yes, that's the difference. Yes.
Okay, so they did have a control, and they did find that the guys that got the SBRT did better than the guys who didn't. And
Right.
was it significant, the difference?
I think it was, or else I wouldn't have put it on this slide.
Okay.
Although
Can
some of the
someone
other,
quickly can someone quickly define Ebscopal effect?
okay, the Ebscopal, well, maybe we have, I thought I saw our expert on the call. Dr. Mark, are you here?
Yes, I am.
Oh,
So,
hi.
so could you do
So,
that?
so the Ebscopal effect is basically saying that treating the primary, either with radiation or surgery, but in this case, with radiation, is going to sensitize and cause a response and reduction in metastatic disease. And there have been some trials looking at that where in the past, if someone had metastatic disease, they would just spot treat that. Now, there's some evidence that suggests Ebscopal effect may make it more likely. I was hoping for that after my local treatment did not take all the disease. But all my medical oncologists say they don't believe that's an effect in the prostate. So I think we need better, well-designed studies to say whether it's a real phenomenon or not.
Right. I mean, they didn't look at immune system parameters, which would have been nice. Okay, moving on. Okay, so here we are for PSMA PET. And obviously PSMA PET has been, there was, I will say that there was a talk at this meeting from Australia that was probably the best scientific talk or medical talk I've ever heard in my whole life. And it was about sort of the Wild West of PSMA PET. And these are two examples of what can happen, that basically here, one is a trial, phase 2-3 study, where they looked at a sub-analysis of disease stages in prostate cancer patients with recurrence or metastasis, and compare that on conventional imaging. And what you can see is that they upstaged 19 of 33 patients, of which nearly 100% were confirmed by pathology. And then from M1, they upstaged 10 of 64. On the other hand, they also downstaged 22%. So, I mean, I think everybody is agreeing that PSMA PET has some real advantages here. And then here in the second study, sorry about that. Condor, it's again a sub-analysis of whether they could localize and predict by, I don't understand what they call standard of truth. And here they said that they localized metastatic lesions with high correct localization rate in men with B-cell resistant who had negative or equivalent baseline imaging. So again, adding to the potential value of PSMA PET as an imaging modality. And I think we'll see more of this as time goes on. Questions? Okay, here's, Len, maybe you could talk about this one.
Okay, so Herb and I both like this a lot. This is a taxane, but it's not docetaxel, it's not cabazitaxel. It's a different structure, and it's so it's a chemotherapy. However, unlike the others, which require an IV infusion, this one is oral, so it's a tablet. It has basically the same mechanism of action, whereby as a tumor cell is dividing, it messes up the cytoskeleton that enables the cell to divide properly. So, and that kills the cell, prevents it from dividing. So what they have found is that so far, this is still just phase 2. I think Herb said they're starting phase 3 very soon. That the efficacy is equal, at least equal to docetaxel, and it doesn't have the most serious side effects that docetaxel has, which is immunosuppression, neutropenia. People who've been on docetaxel know that they have to give you something to boost your white cell count. Otherwise, you could wind up in the hospital and be susceptible to infections. So this particular chemotherapy does not require that, because it doesn't cause neutropenia or bone marrow suppression, and it also has just very mild to moderate side effects of GI toxicity and nausea, vomiting, less than docetaxel. So basically, and even less alopecia or hair loss. So basically, it's at least as effective and has far fewer side effects, and it has a convenience of oral dosing.
Right, I also think there was less peripheral neuropathy.
Oh, that's right. Yes, I forgot. That was an important one as well. Less peripheral neuropathy, which almost everyone who takes docetaxel gets that to some degree.
And this trial is it's out of Hopkins. So one thing they said is this is the end of the phase 2 trial. They've got to dose 63 milligrams, and then they say this quarter they're going to start a phase 3 trial called Veracity.
So,
Oh, and yes, one other thing I want to add here, Herb. This drug also, well, let me back up. Most chemotherapy drugs like docetaxel, eventually patients develop resistance, and one of the mechanisms of resistance is due to a protein called P-glycoprotein, and this is a cellular pump that pumps out of the cell toxic substances, and of course these drugs are toxic. So it will take the docetaxel and pump it out of the cell so it can't kill the cell. But this drug here, Veru-111, it is not affected by these P-glycoprotein pumps. So the preclinical study showed that it had some efficacy against docetaxel resistance.
Mm-hmm.
I think those are in prostate cancer cell lines and also in preclinical models. So it looks like a very promising drug.
And then, well, and then Len, you want to talk about this too?
hold on a second. Let me just ask a couple of questions. One point on Veru is that it's led out of Hopkins, but it's available in many other states: Colorado, Florida, right, Indiana, Louisiana, Maryland, New York, well, Ohio, Pennsylvania, Texas, Virginia.
Well, but that's, Rick, that's not clear where the, because they ended the phase 2 trial. I don't know where the phase 3 is going to be.
Yeah, I mean, I accept that, but my guess is that they'll probably, I mean, most likely when they set them up like that, they set them up to do phase 1, 2, and 3. They hope they'll
Okay.
proceed. But it's not, my point here, guys, is it's not just at Hopkins.
Right. Correct.
Second is, Len, when you said it, what do you mean when you say it's docetaxel resistant? Is that what you said?
It showed some efficacy in cells that were resistant to docetaxel.
Ah, okay. Thank you.
Yeah.
Next. I
Yeah,
want
so
to
this
get through our slides.
Yeah, so this one is similar in that it's an oral chemotherapy drug, but it's unlike the one we've just discussed. This one is docetaxel. It's just an oral formulation, and what they do is they administer it with an antiviral drug called ritonavir, which enhances the bioavailability, which means the drug is absorbed better. And we can go into that. We don't really need to go into that, but it does that by a kind of competitive inhibition of the enzymes that would normally break down the docetaxel.
Right. And this was a Nick Vogelsang trial.
Oh, right.
And the same thing here, you see at the bottom, mild and reversible GI toxicity, myelosuppression and neurotoxicity were low to negligible. So this is another good drug to keep an eye on.
Right. I agree. Okay. Radium-223. And then
Guys, I've got to just tell you, you can
we
only
didn't
go
make
past,
it. Okay.
you can only go past 3:40, past 45 minutes if Bill Franklin agrees.
Okay.
Okay.
Well, we better. This
You,
is.
you have to have Bill Franklin's approval because he's on the line here.
You guys are good. Keep going. I'll just skip paying the water bill this month.
Okay. But basically, the last is basically radium-223 and basically in combination. And then they used it with pembrolizumab, and it did not do well. However, radium-223 plus enzalutamide beats enzalutamide alone. And that you can see in this table down here. And while the p-values, I mean, the TNNT sheet got a p-value of 0.06. Median progression-free survival difference was 18.7 by 8.4. That's a 0.033. That's pretty damn good. So this combination is something to think about in medicine. In that, and then here, basically, this is another one that says, when should you use radium-223? Do you want to use it early or late? This is sort of, are we better to use it sooner or later? Here's the comparison. Red is the people who got it later in their disease. Blue is the people who got it early in their disease. And you can see here, like many other treatments, the earlier you get it, the better off you are. So if you're thinking about it, if you need it, I mean, I think people are thinking of using this much earlier than I mean, sort of right away if you become castration resistant. Because this model, these are certainly big significant differences. With a hazard ratio of 0.7, you can see the big difference here. And that's the end of our presentation. Any questions?
First of all, thank you so much for doing this. That's not a question, but I think everybody in this group is really, really appreciative. And what we'll try to do, I'll work with Jake, and we will load this onto YouTube, but we'll blog it, and in the blog we will attach the PowerPoint, so that if you take it, if you watch it from the blog, you'll be able to get the slides as well. We can't put slides onto YouTube.
And I guess both Len and I am speaking for Len, so I don't know. Will we have, if you have, just email us directly if you have any particular questions where you want more data about any of this stuff.
Yeah, sure.
This
So
is Jerry. Got a quick question. Was there any research presented on any of the bite trials?
There was it wasn't particular research. There were sort of discussion sessions where they mentioned the bites, but I don't think the bite trials were really prominent at this meeting. Lynn, I don't remember any. I think we would have put it in had it been there.
Yeah, I agree.
They're just beginning, and I think we'll see more next year.
yeah, I think it's early days for reporting on those bite trials, Jerry. I think that's the big issue there.
Okay.
Okay.
Herb,
Take
this
care.
is Gary Peters. How would we email you, Erlen?
You can use my ANCAN email address, herb@ancan.org.
And mine is len@ancan.org. Pretty simple.
Thank you.
Okay.
I'll put those both in the chat window. I guess you'll know which one is Len and which one is her. So
Thank you, Rick.
yeah, we try to keep it simple here.
Thank you.
So guys, we're going to close this room down because we have to separate the two recordings, and then we're going to reopen it for our regular session, which will start. It's going to be moderated by Len, and it'll start in 10 minutes. Okay, so go refresh yourself, pee, do whatever else, and we'll see you soon. Goodbye.
How many slides were there total?
You have to write to them to ask them. Len's a pretty honest broker, so you're gonna have to write to Len and ask him.
All right.
Goodbye.
All right.